Okay, so good evening, everyone, and Happy New Year to you. Today is the 11th of January, 2023. I'm Sharif Fawad, Consultant Bariatric Surgeon at Derby and Chair of Professional Education at BOMSS and on BOMSS Council. It's a journal club tonight, the first of the new year, and I'd like to introduce Roxana Zakiri, who everybody will know, is the BOMSS trainee rep. Thank you also to Mr. Walid Al-Kayat, my colleague, consultant bariatric surgeon from EMBMI Derby. So he's going to chair this evening. And we have two fantastic speakers, both members of the EMBMI team, who will be giving the surgical paper and then the IHP paper. So before we move on to that, just a quick reminder that the next session will be on the 25th of January. So that's the fourth Wednesday of the month. And I've got a vested interest in this session, so I asked Kamal Mahwar, professor of surgery at Sunderland, to give his honest take on the one anastomosis gastric bypass. So everything you wanted to know about OAGB will hopefully be covered in that talk. So that's Wednesday, 25th of January here at 8 p.m. But let's get back to tonight. Journal Club, I'll hand you over to Walid Al-Kayat. Thanks, Walid.
Thank you, Sharif. Thank you, Roxana, and thank you, BOMSS, for giving us this opportunity to present the first Journal Club. Happy New Year, everyone. So to make a quick start, we have two papers to start with today. And when we have a surgical paper, will be presented by our Senior Bariatric Fellow, Mr. Abu Awad Mahmoud, and it's about the impact of sleeve gastrectomy on GERD and esophageal motility, and then that will be followed by an AHP paper to be presented by Mrs. Carol Green, one of our senior bariatric clinical nurse specialists. So I may, without any due notice, I'll give the floor to our fellow, Mr. Abu Awad Mahmoud. The floor is open for you to start your first paper presentation.
Hello. Good evening, everyone. Thanks, BOMSS, to give me the opportunity to present today in Journal Club, January 2023. My name is Mahmoud, Bariatric Fellow at Royal Derby Hospital. We move to the paper, please. Sorry, I don't have control on my slides. So I'm presenting impact on sleeve gastrectomy in patients with esophageal motor disorder. This is a very interesting paper published in France, in the University Hospital of Nantes, on the journal Surgery for Obesity and Related Disease back in July 2021. This is well-known authors of upper GI and tertiary unit of bariatric surgery in France. Next, please. So this, the paper has published in Journal Club with high impact factor of 4.7, which is quite relevant for a surgical paper. Why we have chosen this paper? As we know, sleeve gastrectomy is one of the most widely performed bariatric procedure, and the complication associated with the sleeve gastrectomy, GERD, which is one of the most relevant issues. Would this paper help us to predict reflux problems post-sleeve gastrectomy and change operation? We'll see in this paper. Next. So authors in this papers, they were aiming to study the outcomes of GERD and esophageal motor disorder after sleeve gastrectomy in a population with confirmed preoperative esophageal dysmotility on high-resolution manometry. Next. So they made a good introduction of the pathology, explaining the correlation between obesity and reflux and dysmotility, which is common in obese population. Almost 60% of the population, they present dysmotility and GERD. And we can see sleeve gastrectomy can increase the reflux problem because it's affecting the anatomy and the function of the upper GI tract with the anti-reflux mechanism and slowing the gastric emptying. And we know partially the correlation between sleeve gastrectomy and esophageal motility, because either way would increase or reduce the esophageal sphincter relaxation. But we don't have much information about the pre-existing esophageal motor disorder and outcomes after sleeve. And 24-hour pH monitoring and high-resolution manometry normally is not recommended or performed in population before bariatric procedure or sleeve gastrectomy. Next. Authors in this paper, which is a single center retrospective cohort study, they have analyzed 37 patients with a background of pre-existing esophageal motor disorder confirmed on high-resolution manometry, who underwent a laparoscopic sleeve gastrectomy in a period of 10 years between 2010 and 2019. The percentage of the bariatric population was 3%. We'll come back to this number. Remember this. Next, please. So all included patients, they underwent a preoperative checkup, including gastroscopy, scan, high-resolution manometry, and 24 hours pH monitoring. Esophageal biopsies also were performed to exclude any confusing factor like eosinophilic esophagitis. All cases were discussed in MDT. Yeah. So authors as well, they have mentioned the surgical technique, which is quite interesting. It's a standard laparoscopic sleeve. They start the dissection 7 centimeters from the pylorus with the antrum preservation technique. Sleeve gastrectomy performed around 39 French tube calibration and stable line reinforcement with continuous sutures or surgical clips. And whenever found hiatal hernia was repaired with the primary sutures. Next, please. Post-operative follow-up was managed until 5 years, and they have monitored patients' symptoms after surgery, and GERD symptoms were recorded based on clinical judgment, and that can be between cough, pain, heartburn, regurgitation, and PPI treatment consumption over this period. Yeah. So when we analyze the results of this paper, we can see the majority. Next. So female represents 70% of population. BMI, mean BMI 45 with max BMI 49. And we can see other factors like smoking. We have a few people, 4 cases were smoker. Yep. So the preoperative investigations, high resolution manometry showing, next. Yeah, next. So this is the category of esophageal motor disorder. We can see achalasia, 19% of the population, hypercontractile esophagus A, 22, hypocontractile 30, and nutcracker 22%, and ineffective esophageal motility in 8%, which represent in total 37 cases. Yeah, next. So, and the gastroscopy finding showed hiatal hernia in 10 cases, esophagitis 5 cases, gastritis, and H. pylori eradication in 8 cases. And the interesting part that 2 cases with achalasia, they have developed dysphagia where they needed to have dilatation, and then dilatation for almost 6 months, then decision to proceed with sleeve gastrectomy. We'll come to this point later on. Yeah. So analyzing the post-op complications, 3 cases have developed immediate post-operative complication with the dysphagia who needed the laparoscopy, which was completely normal. This is the category of pre-op A&D. Subphrenic abscess, 1 case, acute respiratory distress, 1 case, and 30 days complications were PEs and biliary colic. Main hospital length of stay 3.8 days. Yeah. Right. So in regards of gastroesophageal reflux, what the sleeve gastrectomy is affecting this, and what is the outcome of that? Next. If we see in this table, we have 10 cases in the pre-op, and in the post-op, we have this has resolved in 2 cases, but on the other side, we have de novo, other 2 cases. And yeah, we can see that the percentage has almost doubled, moved from 27 to 49%. And that shows by, next please, the Debester score was significantly increased from 10.2 to 15.9 in the population esophageal motor disorder who had high resolution manometry after surgery. Yeah, next. In regards of esophageal motor disorders, we can see in this table we have 14 cases from 37, and we have also categorized the, just go ahead, please. Yeah, so esophageal motor disorder symptoms were divided between epigastric pain and dysphagia and or food blockage. So we, in the post-op, we found 10 patients with epigastric pain and dysphagia and 7 patients with food blockage. So these patients underwent a thorough process and investigations. At the end of the process, 12 of them needing revisional surgery. We go to the next slide. Yeah, so 12 patients underwent a conversion to Roux-en-Y gastric bypass, which is a quite high percentage of cases. So these are the preoperative esophageal motor disorders. 3 cases with achalasia, 3 cases with nutcracker, and 3 cases with hypercontractility, and the other 3 with hypocontractility. And as we probably all expecting, all patients were asymptomatic after the operation from JED. Next. Right. This picture is showing the high resolution manometry done on just 16 patients of the population who underwent bariatric sleeve gastrectomy, and they managed to compare the the esophageal motor disorders between the pre-op and post-op, and what has changed and what happened to them. The first, if we go next. So the thing that we have noticed here, just come back, sorry. So significant drop in the esophageal sphincter relaxation, which was relevant in this paper to show and to explain why probably sleeve gastrectomy is associated with reflux problem. Next. So if we look in cases with achalasia, they were 4 cases before the sleeve, and the high resolution manometry again showing next, sorry, because a few, again, 4 cases where they have not really resolved. 2 of them showed food blockage and 2 showed GERD symptoms, and there are 3 of them needing conversion to gastric bypass. In regards of nutcracker esophagus, next. Again, 4 cases, we can see 3 of them, they have, again, GERD symptoms. On the other side, 2 of them, the esophageal motor disorders has resolved. But at the end of the day, 2 of these population needing operation and bariatric revision to bypass. Next. Yeah. The hypocontractile esophagus, 4 cases, there were 3 resolved, but then we have de novo GERD symptoms in 2 cases, and as we see, the conversion to Roux-en-Y. Next. Yeah. So the hypocontractile esophagus, 4 cases, and we can see there is no resolution of the dysmotility problem, but 2 of them, they were still with symptoms after the operation, and again, they were needing some revisional surgery. Yeah, next. Yeah. So discussion, we can see de novo GERD is a common problematic after sleeve. This paper shows that the percentage of GERD was 49%, which is quite high compared to a recent systematic review published in 2021, where the percentage was around 20. And in the patients with preoperative esophageal motor disorder, as I said, in this study, the population were 3%, which is lower than other study they have considered in their discussion, which I think it's difficult to compare the 2 studies, as the other paper was published in 2020. They have analyzed just 100 cases of the bariatric population with who underwent a sleeve and bypass. So it's difficult to compare 100 cases to 1,238. And in regards of achalasia, treatment before surgery has not given any better results in post-operative outcomes in this study, where they have mentioned in other study was improved, and achalasia treatment was considered before the bariatric surgery, which I disagree, because we have a paper, the paper they used in their study was achalasia treatment before bariatric surgery, and the treatment was completely different. They used to do a laparoscopic hilar myotomy and POEM endoscopic treatment for achalasia, and patients underwent to gastric bypass, not sleeve gastrectomy. And at the end, sleeve gastrectomy was performed in 7 patients with achalasia because the lack of literature in 2015, which I think it is relevant for achalasia population, despite in 2015 there were some case studies showing achalasia and bypass. Patients with achalasia would benefit from bypass instead. Next. Conclusion, sleeve in patients with AMD associated with worsening of GERD and AMD symptoms. Achalasia and nutcracker are associated with poor outcome post-sleeve. And if you have a patient with achalasia or nutcracker, consider change type of operation if you were planning to do a sleeve gastrectomy. And next, always try to look for esophageal motor disorder in your patient if you're planning to do a sleeve gastrectomy, but it's a tricky situation because most of the time esophageal motor disorder doesn't give symptoms. It can be there, but does not show any symptoms. So critique point of this paper, it's a detailed methods and the clear laid out results in table and the figures, which can give good idea of what they have done and analyzing results. It's a clear discussion which covers all the critical points of the paper, especially achalasia, weakness, and why they have operated on patients with a background of this motility, which represented 3%. On the other side, we have a publication showing 40% of population with esophageal motor disorder goes to bariatric surgery. Discussed the limitation of their study, very well explained. This is a single center study, and it's a retrospective, limited by control group and limited by very limited patients underwent post-operative high resolution manometry. Again, patients underwent esophageal dilatation for achalasia would still be considered candidate for sleeve gastrectomy. This is probably a debate about it. And perioperative investigation result of other results, they have not really given any details about gastroscopy or barium swallow consideration in this category of patients. Question. Thank you.
Thank you, Mahmoud, for this concise presentation of this interesting paper. I think it's very relevant. And yes, the floor is open for questions. If there is any question.
So thanks, Mahmoud. Very nice presentation. I think it's a paper that probably needs to be read in full and sort of we need to spend a bit of time going through the data and the figures. Is there anything in the author's sleeve technique that you think may have contributed to the relatively high rate of reflux post-op of 49%? Anything that stood out for you?
I mean, from their study, it's difficult to tell. They went through a standard sleeve procedure, at least how they explained their technique. It sounds like a very standard sleeve, and I think the reason because of inclusion criteria, all patients, they have got esophageal motor disorder, and on the other side, we don't have a control group to compare this category with the consider them healthy.
So the one thing that jumped at me is that they stitched the staple line. Okay?
Yeah, this is something.
When you stitch the staple line, you'll narrow the sleeve. It's non-uniform. You're not going to get that nice uniform appearance to the sleeve afterwards, no matter how much you try, really. You can't take exactly the same bite all the way up and down the staple line. So perhaps that was contributory, I thought. Now, did all of the patients have the pre-op investigations of high resolution manometry, or was it just the 37? Did everybody go in for a sleeve?
So 37, no, just the 37, and looks like they had some problems. And in their obviously methodology to find this category of patient, they searched AMD on the French program or system of hospitalization, and then start to make a group of patients who then underwent a bariatric procedure or sleeve gastrectomy specifically.
Okay.
Great. Thank you, Mahmoud. We have a couple of questions from the audience, actually. So Rajab Karwest has asked, did the paper look into the effect of Roux-en-Y gastric bypass conversion on the actual motility of the esophagus?
So The paper is supporting the Roux-en-Y conversion in the dysmotility problem. That was mentioned in the discussion, and that was supported by other paper they used in the references, which I mentioned, the Chalasia paper.
But
I know it was small numbers, but they didn't necessarily show the actual measurements or the actual.
No, they have not really. Just in the discussion was mentioned again, as a bypass, it's the choice in case of patient with achalasia and nutcracker.
Yeah. And then we've got time just for one more. We've got a question from Peter Small. He says, this is a retrospective study. Did the new GORD patients have esophageal function tests before surgery? And could they have suffered from the reflux before or pre-op, but it not being picked up?
Yeah, this is a good point. I think the paper is not giving much information about this. As Mr. Awad mentioned, the criteria and inclusion criteria in this paper, starting with searching patients with esophageal motor disorder in their record or database, and then they start to look who underwent a sleeve gastrectomy, and then they picked up these 37 patients to analyze them. And the question, why and how come just 16 patients they underwent high resolution manometry after the procedure? But my personal answer would be because they have developed symptoms between dysphagia, between vomiting, and between hospital admissions. But that was not really mentioned in this paper.
And I guess it kind of brings up the topic, which I guess we could discuss at length another day, about what is the ideal way to screen patients for reflux beforehand, because we could be doing routine OGDs. It's not practical to do all of the more specialist tests on everyone.
Yeah, again, I think between OGD, between pH, 24-hour pH monitoring or high resolution manometry, pick whatever you want to do in case you have concern about reflux and dysmotility.
I think one important point also, yes, the bypass theoretically might be better for these patients because it's a lower pressure system. We've become much more careful in our MDT about in treating these patients with dysmotility, especially proven esophageal dysmotility if they have symptoms and they have a preoperative high resolution manometry, or if we see dysmotility on a barium if it's been done for any reason pre-op. And I guess my worry about converting such patients to bypass is you want to make sure that they don't have a global dysmotility, which also affects the small bowel. So we've got a couple of bypass patients in our books that are just, the small bowel is just not working to push the food through, and they are still having problems with diet even after conversion from sleeve.
I think that's a very important point, Sharif, and thank you so much. We brought this paper under the light because it's a complex subject and we rarely come across, and we don't routinely screen patients preoperatively. So just to highlight.
Good paper. Yeah, good paper. Okay. Do you want to introduce Carol?
Yes, the next paper will be presented by Carol Green, Senior Bariatric Nurse Specialist from the EMBMI. And in this paper, we will describe, it's from EMBMI, this paper, and it's about the use of Saxenda in bariatric patients and a retrospective real-world clinical evaluation of effectiveness. So Carol, the floor is open for you. Thank you.
Thank you. Hello, I'm Carol Green. I'm one of the bariatric specialist nurse at the Royal Derby Hospital, and I mainly deal with the patients in Tier 3. Next. Thank you. So this article was of liraglutide 3 milligrams, which we will call Saxenda, used in bariatric patients. It's a retrospective real-world clinical evaluation, and it's been carried out by the medical team and the members of the surgical team at the Royal Derby Hospital and Nottingham Medical Centre. Next, please. So the research question and outcomes was to investigate the effectiveness of Saxenda 3 milligrams on, oops, let me just get on that more. On body weight, body mass index, treatment. We looked at treatment tolerability and its effect on glycated hemoglobin, HbA1c. The primary outcome was weight change at 26 weeks. We also looked at the HbA1c change and how well Saxenda was tolerated at the dose of 3 milligrams, which is recommended. Next, please. So evidence base has been a bit patchy on the use of liraglutide in weight management. Well, there just hasn't been anything really effective in weight management for a number of years. However, liraglutide has been used, as we know, in diabetes, and that has been noted then that there was some effect on weight and also improvement in HbA1c. So the NICE Institute recommended the use of liraglutide 3 milligrams as a cost-effective obesity treatment for adults with a BMI greater than 35, and the other important factors is to have to be a pre-diabetic. And liraglutide is a glucagon-like peptide. It acts by raising glucose-dependent postprandial insulin and decelerating the gastric emptying. And this then helps to reduce the appetite and therefore food consumption. Next slide, please. So this was a retrospective observational study, and we selected patients who had been referred from the GP into the Tier 3 medical weight management clinic who had a presence of pre-diabetes and also a subgroup of patients who were awaiting bariatric surgery. So the initial data was collected to include their weight, height, BMI, their HbA1c, LFTs, platelets, cholesterol, and eGFR. Oops, sorry. And a Wilcoxon-signed rank tests were used to establish the statistical difference with a p-0.05 changes or in HbA1c and changes in their weight. Next, please. So this shows we had 33 patients in total, and we had then collected their data at weeks, the baseline measurements, then weeks 6, 12, and 26. And you can see that there was, in some patients, there was no follow-up, and we'll discuss that later, and that may have been dropped out. Next slide, please. So out of the 33, the majority were female. They were all class 3 obese, and the median weight was 151 kilograms. And a body mass index of 53, and the median HbA1c of 42, so just in the pre-diabetes range. And then we had follow-up on their weights, BMI and HbA1c at 6, 12 and 26 weeks. And some of the numbers did drop down as we lost some of the patients through their inability to tolerate the medication. And the next slide, please. So The proportion of patients that lost weight was really good, with 72.2% having lost weight from the baseline weight. And this followed through into the HbA1cs, where that improved greatly, and most were taken out of the pre-diabetes range in quite a short space of time. The next slide, please. So liraglutide treatment as an adjunct to lifestyle management was associated with a 12 kilogram, so that's a 7.9% weight reduction, and a 4.5 millimole reduction in HbA1c at 26 weeks. So everyone in the group improved from their diabetes, even the patients that were on the suboptimal dose due to them not being able to tolerate the whole 3 milligrams. However, on the whole, the liraglutide 3 milligram was well tolerated, and the main problems with it is the GI side effects, which cause patients to want to discontinue it if it got too bad, and some were on and off it. And then 40.9% of the cohort achieved a 5% weight loss, which we know does improve many health factors with just 5% loss of weight. So that was at 12 weeks, and that increased to 72.2% at 26 weeks. Oops, can you just go back to that last one? So while the results are quite promising in the short term, and this is basically the first 6 months that they were on the treatment, further investigation in the long-term impact of using liraglutide in weight management is necessary. Next. So limitation. So obviously it was quite a small number in the group, and the patients that didn't tolerate the treatment would not have had the complete follow-up. We were quite dependent, because this all happened in the pandemic, we were quite dependent on GPs to perform blood tests and send the results back. So that there has been a bit of difficulty trying to get the data. And also we couldn't sort of really, oh, can you just go back? Sorry, couldn't really rely totally on the patient's weight as they reported it, because often it was a guesstimate. So the other limitation to this is that there was no control group to differentiate between the impact of liraglutide plus lifestyle management and the impact of lifestyle management in isolation. Next, please. So while the study does show encouraging results in reduction on weight, improved glycemic control in certain high-risk populations, including patients waiting for bariatric surgical intervention, further assessment is required to establish and evaluate the cost effectiveness in a treatment that appears to exemplify the use of pharmacotherapy as an effective approach to weight management. So, stop, I think I'm dictating. Yeah, one of the reasons why the paper was done was to show to the pharmacy that actually using this is an effective and a cost-effective treatment. because it just costs quite a lot of money. So the interesting thing is now we are 2 years, actually this month we are 2 years since we started patients on the Saxenda. So we've got a lot more data and we'll be able to see a better effect on what has happened in those 2 years. But also then we have to consider, what do we do when that 2 years up, because it is only licensed for 2 years. So there are some patients that are going to come to the end of that. So at the centre, our centre, we really have tried to time it so that the patients would be then going on to have the bariatric surgery. This isn't a standalone treatment. It is really to follow on to them having their bariatric surgery procedure, so that hopefully they've reduced the weight significantly, so that reduces the risks going into surgery.
Thanks very much, Carol. Thanks for that. So that's perfect timing on the presentation, because we've just got a few minutes. So positive experience from you in terms of utilising Saxenda within Tier 3 and its ease of use and prescription. Just interested, have you had, so it's prescribed by the hospital, or do you recommend the GP prescribes it for patients?
It has to be prescribed at the hospital. So there have been some difficulties because some of our patients, they do live like in the far depths of Lincolnshire, and they have to actually physically collect the prescription and the medication from the hospital. But you know, most of them, it's only once every 3 months or something like that, so it's not like it's every week. Yeah.
And who was in charge of the dose titration and upping that dose? The side effects. Who did all that work? Was that the bariatric team, or was it a pharmacist, or what?
So Professor Idris, he set all the protocol out, and that was agreed with the pharmacy colleagues. And then we've just I rolled it out initially, and then it's been taken on by the medical registrar now.
Okay.
So she does that.
And in terms of feedback from patients, in terms of acceptability and so on, patients who are on the waiting list and waiting for surgery? Yeah,
I mean, you only got to ask the patients, they do love it. They like the effects, and we enjoy being able to offer them something as well as, you know, that gives them an effect, you know, that they can see something's happening. And especially actually the patients that have had to have their surgery cancelled, and then we've put them onto the Saxenda, so on a slightly different sort of license to what it is for the Tier 3 patients. But that has been helpful in being able to get those patients ready to have a safe surgery.
Okay, we've got a few questions coming in. Roxana, do you want to take a few of these?
Yeah, I think just on the lines of what you were saying about, you've got two groups that you were testing it in within the patients who were on the waiting list versus those to Tier 3. Peter Bassas has asked, which patient group do you think would benefit most from the pre-GLP-1 receptor agonist treatment, from the liraglutide treatment?
Yeah, well, I mean, they're all going to benefit, and I suppose those definitely the patients going to surgery. And I say we've had some that have had like failed liver reducing diets, and you know, they've got to surgery and they've had to be cancelled for one reason or other. So they've come out, gone onto Saxenda, and then gone back to surgery 3 or 4 months later, and they've been able to successfully perform the surgery. So for that group of patients, that is really helpful. As I say, we do stress that it isn't a standalone treatment, and we would want patients to be sort of considering having the bariatric surgery. Yeah.
And Caroline has just said, great presentation as well. Your point about the NICE approval for 2 years is a really good one, because it raises the ethical concerns about when treatment ends. Some will be able to afford to be able to purchase it privately and others won't. Is there anything that we can be doing now in order to kind of help at that 2-year point?
Yeah, well, who
Yeah,
knows?
that was
Yeah.
surgery.
Yeah, well, I mean, that would have been ideally the time frame. So when we get patients referred to us, we don't immediately start them on the Saxenda if they're eligible. What we want them to work with the dietitians for 3 or 4 months and make sure that they're doing all the right lifestyle things. And then we'll consider them, and it's a multidisciplinary team decision, including Professor Idris, to actually make the decision. And in the long term, yeah, we would hope that they get the surgery before they finish the 2 years. Yeah.
Thank you, Carol. Anyway, it's nice to be able to ask one of the authors of the papers about the study.
Perhaps I shouldn't have been the right person to.
And Rajab, just to very quickly answer your question about using it in the super obese. So I've had really good experience in this, and in quite extremely high BMI patients. So BMI 80, 90, 100, who I'm not really that keen on putting a pre-op balloon in them and then removing the balloon, waiting for a bit, and then converting them to a surgical operation. So when we've gone in and we've put them on prolonged liver shrinking diets, 4 weeks, for example, and the liver's still been huge, absolutely huge, that it's just impossible to do any form of bariatric surgery. We have utilized Saxenda, 3 milligrams for 6 weeks in combination with a VLCD diet, and it shrinks the liver beautifully. And it's made technically possible what was an absolutely impossible operation previously. So we'll hopefully write up our data and submit it for publication, because we've got about 8 or 10 patients that we've done successfully in the unit who otherwise would not have been able to have surgery. So I can comment on that. Peter, your comment about results being misleading. So it's fair comment. I think you are right that there is a high dropout rate in this paper, which is acknowledged by the authors due to the difficulties of doing this sort of study and collecting data during COVID. The paper is published and has been sent out. So maybe the slides were difficult to catch the numbers, but they are there in the paper. Feel free to have a look. Okay, so because we've gone slightly over time, thank you very much to all the speakers and to all of you for joining, and to Ethicon for sponsoring. I forgot to thank the sponsors at the start. Next 2 sessions, we've got Kamal Mahwar on the 25th of Jan talking about 1 anastomosis gastric bypass. That will be a very good session, followed by the next Journal Club on the 8th of February will be by UCL team. Okay, so we look forward to seeing you all there. Thank you very much to EMBMI team, and thank you all for joining. Good night all.
Good night, everyone.
Good night.
Good night, everyone. Bye. Thanks.